Welcome to the pharmacology class, and today's topic is neurodegenerative diseases and drugs for neurodegenerative diseases. And we are starting a new section now. It's the drugs that influence the central nervous system, and one of the important diseases is neurodegenerative diseases, and that include Parkinson's disease, Alzheimer's disease, and multiple sclerosis, and amyotrophic sclerosis. So these are 3 or 4 diseases. Actually, Parkinson's disease, Alzheimer's disease, and sclerosis, but sclerosis is different types. So these are the examples of the degenerative diseases that develop when the neurons will die in the central nervous system, and the death of the neurons will lead to the decrease in the function of that neurons, and that is why the treatment is to enhance the action of the left neurons, and that is why the treatment is only symptomatic and is lifetime. So the patients have to take medicines the whole until the whole life. So and the first disease is Parkinson's disease, and Parkinson's disease is developed when the dopaminergic neurons die in substantia nigra. Substantia nigra is part of the central nervous system that has neurons of the dopaminergic neurons that are connected with the neurostriatum, and neurostriatum has so they have multiple endings in the neurons of the neurostriatum, and dopaminergic neurons are inhibitory. So the neurostriatum is displayed here as a moment. Can you see the scheme?
Yes.
So the substantia nigra that is here in the rose color, and it has the neurons with the dopaminergic neurons that are inhibitory, that are red here, and they end up at the neurostriatum that is yellow. So, and in the neurostriatum they inhibit the neurostriatum. So then, and also the neurostriatum has inhibitory GABA neurons that also connected with the substantia nigra, and they also are inhibiting. So GABA neurons are here in orange. So this way the substantia nigra will inhibit the neurostriatum, and neurostriatum will inhibit the substantia nigra, and that is why there is a balance between the neurostriatum and substantia nigra. When the Parkinson's disease is developed, these red neurons, dopaminergic neurons, are reduced, and that is why the inhibition of the neurostriatum is reduced, and that activates the acetylcholinergic transmission, and that will break the balance between the inhibition, and that is why the uh, muscle movement uh, uh, is not is uh, slightly the movements that are voluntary will be uh, not very correct, and there is a slowness in initiating the movements. So these are the typical symptoms of the Parkinson's disease. So that is actually bradykinesia. And also other symptoms include the tremors, rigidity, and usually the Parkinson's disease is developed at the age of 60 and higher, and the higher is the age, the higher is the probability of development of the disease. So and that is why most of the patients are elderly. The reason for the Parkinson's disease is unknown for the most patients, except for the Parkinson's disease is as a secondary Parkinsonism because of the administering the some drugs. So because some drugs can develop Parkinson's disease that mostly include the phenothiazine derivatives and haloperidol. But we will study that later. So the so the reason is unknown, and but there is a destruction of dopaminergic neurons in the substantia nigra, and that reduces the action of the dopamine to the neurostriatum, and neurostriatum is involved in the control of the movement, and so the movement is impaired. So the treatment of the Parkinson's disease is based on the increasing the dopaminergic neurons, so or increasing the dopaminergic action, so to make those neurons that left more active, or decreasing the cholinergic activity. So and these are major approaches to the treatment. The drugs that are used for the treatment of Parkinson's disease include levodopa with carbidopa, that is the precursor of the dopamine, and also the so levodopa is the most effective drug, usually used with the carbidopa, and the levodopa is the precursor of dopamine, and it restores the dopamine is produced from the deoxyphenylalanine, so this is a precursor of the dopamine, and the administration of the levodopa will enhance the synthesis of dopamine in the neurons that are survived, and it is effective in early disease when the number of the dopaminergic neurons that survived are high. And that is why when the treatment is started, usually the levodopa is very effective, but unfortunately the longer is the treatment, the less is the efficacy, and the so the effectiveness of the levodopa decreases when the number of the neurons that survived will decrease. So the less is the number of the left neurons, the less is they will convert the levodopa to dopamine, and that lead to the development of the Parkinson's disease. And the effect of levodopa will only last when the levodopa is present in the body, and usually to increase the effectiveness, the carbidopa is administered together with the levodopa. So the carbidopa is the inhibitor of decarboxylase that will decarboxylize the dopamine in the peripheral tissues and in the GI. So the mechanism of action of dopamine is based on the the mechanism of action of levodopa is based on the conversion to dopamine, and the levodopa will cross the blood-brain barrier and will produce the dopamine in the central nervous system. And usually the levodopa is administered with the carbidopa because the dopamine is decarboxylated in the periphery, and that leads to the undesirable side effects including the nausea, vomiting, hypotension, and arrhythmia. So if we administer levodopa without carbidopa, then most of the levodopa will be destroyed in the GI, then metabolized in the peripheral tissues, and only small amount will pass to the central nervous system. But if we administer levodopa with the carbidopa, then this decarboxylation is inhibited by the carbidopa, and that is why the higher concentrations of the drug appear in the central nervous system and will then be released to the synaptic cleft. And the levodopa is very effective in the first years of treatment, and then the efficacy is reduced in the third and fourth and 5 years of treatment, and also sometimes the dose can be increased, or the combination of the drug can be used to make the treatment more effective. Levodopa is absorbed after oral administration. Usually it is taken on empty food, and the levodopa has short half lifetime, and that is why when the action of levodopa will stop, the symptoms of Parkinson's disease can return, and that is called on-off phenomenon. And the levodopa should be taken on empty stomach, and it's better to take 30 minutes before a meal, because when taken with the food, the absorption is decreased. Adverse effects include nausea, tachycardia, uh, hypotension, and psychiatric problems. The nausea, vomiting, because of the central nervous system action, and tachycardia is because of the action of the on the periphery of the dopamine. And also the saliva and urine are a brownish color because of the melanin pigment produced from catecholamine oxidation. Central nervous system include hallucinations and dyskinesia, and these symptoms are because of the overactivity of the dopamine neurons. Levodopa can also lead to the mood changes, depression, psychosis, and anxiety. So the interactions with other drugs include the increase of the peripheral breakdown by vitamin B, and the hypertensive crisis when administered with the non-selective monoamino oxidase inhibitor. The latter is because of the increased catecholamine production. In psychotic patients, levodopa will increase the symptoms. And patients with heart disease should be monitored for arrhythmias because of the tachycardia. And also antipsychotics are contraindicated in patients with Parkinsons disease because of their mechanism of action. They block the dopamine receptors. But that usually is not required, because Parkinson patients usually don't have schizophrenia. So then the next drug that is used for the treatment is selegiline and razagiline, and these are selective inhibitors of the monoamino oxidase type B that is metabolizing dopamine. And this selegiline and selegiline will not metabolize monoamino oxidase type A that metabolizes norepinephrine and serotonin. The inhibition of the dopamine metabolism increases the levels of the dopamine in the central nervous system, and so actually the metabolites are decreased and the dopamine will increase. So the selegiline can be administered with levodopa, and that enhances the action of levodopa and substantially reduces the required dose. The next group is catechol or methyltransferase inhibitors, and usually the methylation of levodopa by catechol or methyltransferase or COMT is a very small pathway for levodopa metabolism. However, when peripheral dopamine decarboxylase activity is inhibited by carbidopa, so carbidopa will decrease the metabolism by decarboxylases, and the 3-O-methyl-dopa is developed in high concentrations by the catechol or methyltransferase, and that will compete with the levodopa to transport to the central nervous system because they use the same pathway. So and entacapone and tolcapone selectively and reversibly inhibit catechol O methyltransferase, and that will decrease the level of J-O-methyl-dopa and that increases the uptake of the levodopa by the central nervous system. So we can additionally to the carbidopa, we can also add entacapone or tolcapone to the levodopa. And that both agents, levodopa and carbidopa, will reduce the symptoms of the wearing off in patients, and that is why they are effective in the treatment. Both so tolcapone and entacapone are absorbed orally, and they have a limited volume of distribution. They bound to the plasma proteins, and tolcapone has a relatively long duration of action, and entacapone has a shorter duration of action. So, and they are eliminated in feces and urine, and some patients will need a dose adjustment, especially in cirrhosis, so the liver disease cirrhosis, because they are metabolized in the liver. Adverse effects include diarrhea, nausea, anorexia, dyskinesia, and hallucinations, sleep disorders. And also necrosis of the liver can be seen with the tolcapone. and entacapone don't have the liver toxicity, and that is why replace tolcapone. So the next group is a dopamine receptor agonist, and so the dopamine itself, and that includes the bromkriptine, that is an algate derivative, and also ropinirole and pramipexole and rotigotine, and the new agent apomorphine. These agents have a longer duration of action that of levodopa and are effective in patients exhibiting fluctuations in response to levodopa. Initial therapy with these agents is associated with less risk of developing dyskinesias and motor fluctuations as compared to patients started on levodopa. And the bromkriptine, pramipexole, and ropinirole are effective in patients with Parkinson's disease complicated by motor fluctuations and dyskinesias, and these drugs are ineffective in patients who have not responded to levodopa. Apomorphine is an injectable dopamine agonist that is used in severe and advanced stages of the disease to supplement oral medications. So the side effects of the dopamine so actually sedation, nausea, blood pressure decrease, confusion, and hallucinations, especially hallucinations when sleeping, nightmares, very scary. So this looks like an alien. So the bromkriptine is the algate derivative that is derived from the plants. So hope you studied the botany well. And the action of the bromkriptine is similar to those of levodopa, except that there are more hallucinations, more confusion, more nausea, vomiting, and also more orthostatic hypotension. So actually same as levodopa, but more adverse effects. Sounds very attractive for the patient. So but the good thing is that dyskinesia is less common. So in bromkriptine can also lead to the worsening of the psychiatric illnesses. It also should be used with the caution in patients with a history of myocardial infarction or peripheral vascular disease, because it is an algate derivative. It can lead to the pulmonary and retroperitoneal fibrosis. It also contraindicated in pregnancy. So the non-algate dopamine agonists, apomorphine, pramipexole, ropinirole, and rotigotine, are used for the treatment of the Parkinson's disease, and apomorphine and rotigotine are injectable and also can be used transdermally. the apomorphine is injectable and rotigotine is transdermal, and the pramipixole and ropinirole are orally available. The apomorphine is used for the acute management of the advanced Parkinson's disease. Rotigotine is administered as once daily transdermal patch that releases the drug for 24 hours. And the unlike the procryptine, these agents don't exacerbate the peripheral vascular disorders, and they don't have a fibrosis, but there are other adverse effects are at the place, so the same adverse effects as for the bromocriptine. Pramipixole is excited unchanged, and the cimetidine inhibits the renal tubular secretion of organic bases and may significantly increase the half-life of pramipixole. And also the fluoroquinolone antibiotics inhibit the cytochrome P450 that may lead to the inhibition of the metabolism of ropinirole, and that also requires a dose adjustment. So the next drug is Amentradine, and Amentradine was developed as an antiviral medicine first, but later the anti-Parkinson activity was discovered, but the mechanism of action is not well known. So, but still, Amentradine can be used as an anti-Parkinson drug as well. So, and also the antimuscarinic agents can also be used, and antimuscarinic drugs include benztropine. So benztropine is the derivative of the atropine, so I'm calling a blocker, and also trihexyphenidyl. Trihexyphenidyl is used for anti-Parkinson drug. Procyclidine and piperidine. So piperidine. So these are the anti-muscarinic agents that block the cholinergic transmission, and this helps to correct the imbalance in the dopamine acetylcholine ratio. Antimuscarinic agents can lead to the mood changes and produce serophthalmia, constipation, and other unwanted side effects. And also the visual problems and they also inhibit the peristalsis of the GI and contraindicated in patients with glaucoma and prostatic hyperplasia and also with the pyloric stenosis. So the next part is the drugs for the Alzheimer's disease, and Alzheimer's disease or dementia is a different disease that is usually characterized with the accumulation of the senile plaques like beta amyloid accumulations, formation of the numerous neurofibrillary tangles, and loss of cortical neurons, particularly cholinergic neurons. The treatment is aimed for improving cholinergic transmission with the central nervous system or excitotoxic actions resulting from the overstimulation of the NMDA glutamate receptors in selected areas of the brain. Pharmacologic intervention for Alzheimer's disease is only palliative and provides modest short-term benefit. None of the medicines alter the underlying neurodegenerative process. So the anticholinesterase inhibitors include the galantamine, galantamine, rivastigmine, and they are more selective for the central acetylcholinesterase and the memantine is the NMDA receptor antagonist. So the mechanism of action is the based on the blocking of the NMDA receptors, because the stimulation of the glutamate receptors in the central nervous system is very important for the memories. So but when you overstimulate the NMDA receptor, then that may result in excitotoxic effects, and this is suggested as a mechanism for the apoptosis, and then so the cells will die and the memories will die as well with them. So binding of the glutamate to the NMDA receptors assists in the opening of an ion channel that allows calcium to enter the neuron, and then excess intracellular calcium can activate a number of processes that ultimately damage neurons and lead to apoptosis. So memantine is an antagonist, and it blocks the NMDA receptors and limit calcium influx, and that toxic intracellular levels are not achieved. And memantine is well tolerated with few dose-dependent adverse effects. And usually symptoms are indistinguishable from the Alzheimer's disease, and can be used as a combination. So, and the last group is the drugs for multiple sclerosis, and multiple sclerosis is a autoimmune inflammatory disease that demyelinates the neurons. So neurons are usually myelinated. That increases the speed of the neuron excitation and transmission, the neuronal transmission, and demyelinating will decrease the speed, and that is why the sclerosis will develop. And multiple sclerosis usually is a chronic, relapsing, and progressive disease that may span 10 to 20 years. So there are several groups that are used for the treatment of the multiple sclerosis, and disease-modifying agents are most effective, and the major target for this medication is to modify the immune response through inhibition of white blood cell mediated inflammatory processes that eventually lead to myelin sheath damage and decrease in inappropriate axonal communication between cells. First group is the interferon B1A and B1A. So these are interferons B, 1A and 1B. The immunomodulatory effect of interferon helps to diminish the inflammatory responses and lead to demyelination of an axonal sheath. Adverse effects are depression, local injection reactions, hepatic enzyme increase, and flu-like symptoms as with any interferon. The second is glatiramer. Glatiramer is a synthetic polypeptide that resembles myelin protein and may act as a decoy to T-cell attack. The next one is fingolimod. Fingolimod is an oral drug that alters the lymphocyte migration, resulting in fewer lymphocytes in the central nervous system. Then teriflunomide. Teriflunomide is also oral and will lead to the inhibition of the pyrimidine synthesis that will decrease the concentration of the active lymphocytes in the central nervous system, and it should be avoided in pregnancy. Dimethyl fumarate is also oral agent, and that will alter the cellular response to oxidative stress to reduce the disease progression. Natalizumab is a monoclonal antibody and is only used when the treatment is ineffective because it's very expensive. And mitoxantrone is a cytotoxic and anthracyclic analog that kills T cells and may also be used for treatment of the multiple sclerosis. So, and also there is one drug for the amyotrophic lateral sclerosis, or ALS, and ALS or amyotrophic lateral sclerosis is characterized by progressive degeneration of motor neurons, resulting in the inability to initiate or control muscle movement. And riluzole is an NMDA receptor antagonist and indicated for the treatment of the amyotrophic lateral sclerosis. The drug will improve the survival time and delay the requirement for the artificial ventilation support for the patients with anti-amniotic multiples amniotic lateral sclerosis. So I think that is all for today, and thank you for watching. And if you have any comments, please feel free to leave them below. See you next week.